Let's talk about this cool case of gout of the knee. This was a 45-year-old male athlete who presented to the ortho clinic with a newly diagnosed mass in his left patellar tendon. He'd had this for about a decade. It had slowly gotten worse with increased pain and swelling. That was despite a diagnosis of patellar tendonitis, despite physical therapy and NSAIDs. He was initially able to continue the marathons and triathlons that he competed in, but he was forced to stop due to worsening pain over time. He did get diagnosed with gout a couple years earlier. This was well controlled on allopurinol, and uric acid had been consistently within normal limits. This is not our patient, but this is an interesting picture of a patient with gout. And you can see the tophaceous deformities of the metacarpal phalangeal and proximal interphalangeal joints on this patient's hands. Pretty profound. Distal interphalangeal joint. And then in the knees, you also see tophaceous deformities as well. This is a really prominent one here at the insertion of the patellar tendon. So not the same patient, but you can get a sense of how bad gout can get. He had no other medical or surgical history. On physical exam, he had tenderness and a palpable fullness over the patellar tendon, which was painful when extension was resisted. Otherwise, his exam was normal. He had an x-ray pre-orthopedics, which was generally normal joint space, normal patellofemoral space, no large effusion in the suprapatellar recess here. The silhouette of the patellar tendon was okay. On the sunrise view, you see a nice patellofemoral space here. Now we get to the sagittal view of the MRIs, the T1 image. You can see that patellar tendon is not this nice linear sort of tendon here, but there's this mass on the back of sort of uncertain significance and etiology here. You can also see it on the T2 weighted image. You see no large patellofemoral joint effusion or knee joint effusion. The cartilage looks pretty good. You're catching the ACL here. And then you have another view here in the axial plane and another view here as well, not as well visualized in my opinion. And another axial cut. So this guy has gout. Let's talk about gout. It's an inflammatory crystal arthropathy that is characterized by deposition of monosodium urate crystals into the affected joints. It presents with episodic joint pain, redness, and swelling, most classically at the first metatarsal phalangeal joint, and is managed with NSAIDs and urate-lowering therapy. These illustrations on the right kind of fill you in here. So here's a red, hot, swollen joint with uric acid deposition in the first metatarsal phalangeal joint. You can see how edematous this looks. From a pathophysiology standpoint, you have increased uric acid intake, which leads to hyperuricemia, uric acid deposition, and immune response. And then you have an acute sort of arthritis. And then if you don't see anybody or do anything about it, you can develop chronic gout. There are really 4 stages. The first is asymptomatic hyperuricemia, which a lot of individuals may have and never progress to gout. So a uric acid level being elevated in a vacuum doesn't necessarily mean anything. You need to have a patient who has symptomatic joints to interpret that test. Acute gout is characterized by sudden redness, warmth, and swelling, and then you can have this intercritical period between gout flares where you're asymptomatic, but the gout is not gone. It's just at a low-grade sort of smoldering inflammation. And then you can develop chronic gout with repeated flares, crystal deposition, deformities, tophaceous deposits. Here's a table outlining some of the risk factors, dietary and otherwise. So meat, alcohol, and seafood are classically associated with this, sweet and soft food drinks. And then on the other side, protective things, dairy, oatmeal, purine-rich vegetables, and coffee consumption seem to help protect against gout a little bit. Other risk factors, dehydration, recent surgery, traumas, and hospitalizations, concentration of serum uric acid, so if you were really dehydrated, alcohol consumption, obesity, and physical inactivity, unsurprisingly, and then some medications like certain diuretics like hydrochlorothiazide, aspirin, cyclosporin, and when you initially start your lowering therapy, you can get a gout flare. History and physical can be tricky, right? Sometimes these patients just have a little bit of minor toe pain or knee pain, but typically sudden pain, swelling, tenderness, redness, most commonly in about 2/3 of patients in the first metatarsal phalangeal joint. You should see some component of erythema, warmth, and swelling, tenderness, restricted range of motion, and often a visible effusion. Diagnosis is clinical. I would say the gold standard, at least historically, was arthrocentesis. A little more complicated than that now. There's good American College of Rheumatology guidelines on diagnosing gout. But the arthrocentesis should show monosodium urate crystals, which is diagnostic. However, not every patient is going to have that in their TAP. Imaging is often normal. There are some non-specific findings such as swelling, erosions, and tophaceous deposits, which are, I guess, a little bit more specific. And these things can be seen on X-ray, MRI, and ultrasound. On the X-ray here, we see some pre-patellar swelling in the prepatellar bursa. We see some calcification of the patellar tendon. We see maybe a loose body here. We see loss of the patellofemoral joint space. We do not see a large joint effusion. Maybe there's some degenerative changes down here in the femoral tibial space. And these two black arrows are pointing towards some changes in the cortex of the distal femur here as well. So there's a lot going on in this X-ray. This patient had gout. In terms of management, there's sort of three flavors. There's lifestyle modification, acute management, and then urate lowering therapy. And so lifestyle is avoiding all those high-risk foods we talked about, including sugary drinks and alcohol. In the acute phase, you need some type of anti-inflammatory, which can either be NSAIDs, colchicine, or steroids, along with cryotherapy. Then more chronically, allopurinol, maybe pegloticase, and if these patients are complicated, of course, they should see a rheumatologist. Our patient did well. He was consented for the OR, right? He had this knee mass. They didn't know if it was a tumor. They went to the OR. When they incised the mass, a white caseous material was excised. Initially, gout wasn't considered, but a specimen was sent to the lab and was positive for uric acid. Pardon my typo there. This patient did really well. He had no recurrence of his mass. His pain resolved. He returned to athletics. And an MRI about a year later showed some scar tissue, which is unsurprising, but no recurrence of the gout or the tophaceous findings. The three key points. This was a highly athletic 45-year-old male who had an intratendinous patellar tendon mass, which was found to be gouty tophus, despite no history of this problem, and his uric acid was well controlled. Imaging studies suggested a benign lesion, but in the operating room and with histology, he was confirmed to have gout. And he had an excisional sort of biopsy and tendon repair and basically returned to athletics. He did great. A subsequent rheumatologist managed his symptoms with urate lowering therapy, and he had no further recurrence of gout in the knee.